do you want to tell us about the tractor?
I don't want to offend any Kubota people. The Massey Ferguson has a larger size bucket, and it is red.
Nothing better than a red tractor.
Nothing better than a red tractor.
Well, hello and welcome to the Hat Rack. It's Bill McCauley speaking, the Associate Dean of Continuing Professional Development at the Schulich School of Medicine and Dentistry. And as always, I'm joined by my colleague, Leslie McAdam. How are you?
Good. Welcome.
Thank you. It's good to be here. I'm really excited about today's interview, actually. We're going to be focusing on skills acquisition, right? Which is something that people don't often think about, I think, as part of their CME or CPD, is sort of getting new skills, maintaining new skills.
Yes, and we're going outside the province to talk to someone.
We're going national, actually. We're going national.
Right.
We're going maybe even international. So our guest today is Dr. George Kovacs. And George is he's an emergency physician. And he's actually a graduate of the Schulich, or at the time, Western Emergency Medicine Residency Program. So I've known George for a long time. He's a full professor of emergency medicine at Dalhousie University. He's got a long list of accomplishments. He's involved in all sorts of clinical things, trauma team leader. He's the director of the province of Nova Scotia's air ambulance program. He directs something called the Clinical Cadaver Program, which we're going to be hearing a little bit about. He's a writer. He's a coveted lecturer on airway management. He does it all. And most importantly, he is a family man. He loves spending time at his cottage on the Medway River in Nova Scotia. And apparently he's got a significant love for Massey Ferguson tractors.
And a love for the tractors.
A love for the tractor.
All right.
Yeah.
That's interesting.
So, welcome, Dr. George Kovacs.
Thanks very much. Thanks for having me, and I'm looking forward to address the question of why I have a tractor, but we'll save that for the end. It's great to be here.
Well, yeah, and what people are gonna want to hear is why specifically Massey Ferguson. But anyway, we don't have any sponsorship here, so maybe that doesn't matter. So listen, we're going to talk about skills acquisition, and I know you did a Master's of Health Professions Education at the University of Illinois, Chicago, and part of your master's work was looking at skills acquisition at that time. So how did you kind of develop an interest in skills acquisition at that stage?
So a combination of two things, very motivating things. First was fear, and the second one was acquired sometime later that maybe I'll talk about, which is stupidity. But when I finished back in 1990, you finished your internship. I finished my internship on a Wednesday, and that Monday I was working in a small town in Cape Breton. I had a full office booked, and then I was working my first shift in emergency medicine in that small hospital, which would have been me and a nurse. I finished up the day. Was going to meet some patients at the hospital, and my experience at that point in emergency medicine was a month rotation. And anyway, there was a pretty tragic crash that occurred. And back then, the pre-hospital system was operated by taxi drivers, and so taxi drivers would get out of their vehicle, drive to where the ambulance was. They get out of their vehicle, hop in the ambulance, and go pick up a patient. We knew that a crash had happened, and there was going to be a patient coming in. Was waiting there, and again, I just finished my internship. I thought it was pretty cool. I knew what I needed to do. I'd taken ATLS, I'd taken ACLS, and then I remember opening up the back of the ambulance, and the provider there, pulled this person out with their legs and put them over their shoulder and dropped them before me to look after them. I won't get into too much more detail, but I don't remember much of what went on in our resus room, which would have been a nurse and the the cab driver, medic at the time. But I do remember driving to the regional center as I was bagging this patient, and I didn't want to feel that way. It was something that frightened me, and maybe sort of reflect on what skills I had and didn't have. And so that was really sort of the motivating factor for two things. One, for me to ultimately go back and do residency in emergency medicine, but, appreciate the fact that procedural learning was the poor cousin of the traditional cognitive model that we're all used to. And there was a program in University of Illinois in Chicago, and there weren't too many master's programs available. So as a resident, I was given the privilege of going down there. It's very classroomy there. And the project that I chose was to examine, what's behind the history and evolution of where we are in terms of procedural learning. So that's the abbreviated version.
Well, I think you describe a scenario that many fresh physicians of any discipline might go through, where you finish all your training and then all of a sudden you're presented with the real world, and particularly in emergency medicine and rural emergency medicine across Canada, where so many people are perhaps less prepared to take that on, and less familiar environment in an area where they're under-resourced and not a lot of supports around, and so that fear factor is a huge one. Back in those days, and maybe still the case, the mantra for teaching procedural skills was see one, do one, teach one. And I know we've talked about this in the past, but do you think that is something that still goes on? And do you think that mantra still is a valid concept?
Yeah, so I'd be very pragmatic about it. I mean, yes, it still goes on, for sure. And so that was Halstead, I think, was in the late 19th century. And if you think about it, what I think was meant to do is describe a progression, right? A learning progression, right? So you do see it, and you learn about it, and ultimately you do it, and the representation of ultimately doing it is being able to teach it. I think where it's gotten into trouble and has been, beaten on in the literature is the one, right? See one, do one, teach one. But, I don't think that was sort of the, intent piece. And obviously that's completely inappropriate. And it'd be, I think, silly to sort of even reflect on that and say that was that time, right? That was just what it was. But at least what it was is recognizing that we have to, approach this. And to follow up, there's a person that I know you know of by the name of George Miller, who's a well-known educator who wrote a paper, I think, back in 1990, and it's called Miller's Pyramid. And, it talks about this progression from those who know, those who know how, those who show how, and ultimately those who do, right? And again, that's this progression that applies very well in the context of procedural learning.
I think one of the big motivators, and I've talked about this on previous episodes, one of the big motivators for physicians acquiring any skills or acquiring new knowledge is seeing what their colleagues are doing. So you are motivated by working in an environment where you see people are starting to do things. And in emergency medicine, you could use sort of the acquisition of bedside ultrasound skills as a good example of that. And you see people starting to do this, and you realize, you know what, I need to learn that skill too, because if I'm going to be sort of on par with my peer, if I still want to be a peer, then I have to do that. And I think that's probably a little bit of what happened with your AIM program on a much bigger scale, where people just started to say, hey, I need some more. I'm seeing other people are using more advanced airways skills, tools, and techniques, and maybe I need to learn some of those things, and maybe this will make me more comfortable, and maybe I'll be able to provide care more effectively and more efficiently. And I think you get that critical mass, and then you get some momentum that builds up.
I think what you're getting to, which is an important one, and is things that are high acuity, low opportunity, as an example. And this is where procedural skill learning is everybody's going to get opportunities to perform IVs. People are getting opportunities to perform chest tubes, but there are going to be procedures that might be a once in a lifetime scenario. So, what do you do about, once you learn it, maintaining that? And even there's a more fundamental question that happens, and which I think is wrong, is that are people taking it off the menu because they won't get an opportunity necessarily to create that educational context for it? And I think that's dangerous, because everybody's expected, the public's expecting that you have a range of capabilities to perform, and you're not going to do a thoracotomy in a small town, right? We're not talking about that. You might have to do a cricothyrotomy. You might have to, deliver a breech. You might have to do these sort of things. So how do you address that? And my understanding from the literature and from a pragmatic thing is, the irony is that there's two effective interventions. One is overlearning, and the second one is what I refer to as system one training. So the irony is, for high acuity, things that you don't see very often that you have to do, that the best way to deal with that is to overlearn it. So how do you overlearn something that you don't see? And this is where it gets down to numbers and time and what's considered an educational experience, right? So an educational experience could be that you're every time there's a resuscitation and there's somebody else in the department, that they go in and share that experience, right? So you have more eyes there, to be a part of that.
Take advantage of any opportunity.
Absolutely, yeah.
Absolutely.
It's about, there's 11 steps to do a cricothyrotomy, but all of I'm doing with my hand right now are those 11 steps, and they are a practice opportunity where you formulate that psychomotor memory to execute it, right? So that when you do it on a whatever fidelity mannequin or whatever, you can implement that without having to sort of think about that. So these are opportunities that you can create, even though they're not there, and it becomes more graduated at the bedside or in other scenarios such as clinical cadavers. So and this is, yeah.
So it I was just going to say, it's interesting that it reminds me of, when you see divers, Olympic divers, and they are going through their routine on the swimming platform, not on the diving board, and they're going through every maneuver that they're going to do before they do it. It's that mental imagery and some physical movement as well. Is that something that physicians should be doing? Do you think that's something that we naturally do? I'll answer my own question and say that I do that. I mean, I've been working as an emergency physician for 31 years, and I've done 2 cricothyrotomies. But if I had to do one this afternoon, I could do it because I've done it before, and because I think about it when I'm managing an airway. What would I do if I had to do that cricothyrotomy, and sort of go through it in my mind, that mental imagery, that mental gymnastics? Is that an important component of it?
Totally. Yeah. When I say, when you say you still do it, and when I go into a resuscitation room, I said, listen, I got to go to the bathroom. It's because I'm 60 and I need to go to the bathroom. But when I'm there, I'm thinking about the procedure. I'm going through it in my head, and I'm also doing positive self-talk. Right? Is that I said, who's in the room with me? Is Bill McCauley. They're in the room with me, and if I do the things I was taught and that I practice, things are going to be fine. As opposed to and we know that changes your chemistry and can affect our ability to perform. It's not that, oh my God, something absolutely terrible is going to happen. So absolutely, that is something that should happen. And if you think about it, concert violinists, fighter pilots, um, athletes, they spend 95 to 98% of the time practicing and very little time performing. In medicine, we spend all of our time performing and very little time practicing. And what are the stakes? Well, the stakes are, yes, a Olympic medal, a world record. The stakes are, somebody who's, as they say, fixing to die.
So let's talk about the practicing bit then, because and this is something that I know you love to talk about, because when most people talk about practicing and skills acquisition, they often talk about sim labs, high fidelity simulation situations. But you have brought a program to Dalhousie called the Clinical Cadaver Program, which is used for skills acquisition, skills maintenance, high fidelity situations, simulation situations. Can you just explain to us what the Clinical Cadaver Program is all about and what you use it for at Dal?
Yeah, so the cadavers that originally were there were in the 1800s, were those who had just died, so there's a history and a progression, and then there's a fascinating contextual piece about how they evolved to where they are, which is, the typical formaldehyde preparation that are often referred to as shades of gray when you look at. So they're all anatomically correct, but they are rigid and don't respond in any way. It's great to learn anatomy there because you can look at Gray's Anatomy textbook, not the television show or whatever. It's they can look at this and say, okay, yeah, I know they're not, the arteries aren't painted red and blue and the nerves yellow and that type of thing, but they can sort of see that. What this is a different type of preparation that ultimately uses a combination of alcohols and a very tiny insignificant amount of formaldehyde. We learned this through a mutual colleague and mentor, Rich Levitan, who is an amazing educator, emergency physician, now actually works in a very small community in New Hampshire. He's done these courses in Baltimore where they were being prepared a certain way. And there's a gentleman by the name of Ron Wade, who's a Vietnam vet and was interested and developed this technique in which you prepare the cadavers and they would last a little bit longer and retain their dynamic fidelity in terms of their ability to move and respond in a way that when you flex an arm or open a mouth or do an intubation or whatever procedure. So what ended up happening is around 17 years ago. Myself and a colleague, Adam Law, went down to Baltimore because we were trying to figure out if this device was going to work in human tissue, and we went down to where they have been performing this for a period of time, and we really forgot about the device. We just had that first experience with one of these cadavers, and we just said, "This is crazy. It's just so amazing." And we left the next day. I walked across the Tupper building. I went up to where the anatomy lab was. I knocked on the door of the department head of anatomy and neurobiology and walked in. It was Ron Leslie there. And I said, "Hi, my name's George. We're down. Have you ever heard about this?" And the answer was no. And I said, "Well, this would be really good for you guys to your team to go. It was Ron Leslie and Rom Sandusky who was there, and they said, "We'll apply for funding." I said, "Don't, we'll figure out funding after. Just go." And ultimately, I paid for them going, and they came back, and the next day produced the first, and we've referred to the term as clinical cadavers because it's what they are. They're meant for not anatomical teaching, but to learn clinical procedures on. And that's, so started doing that. It was one there now. I think we take in close to 170 a year through the Human Body Donation Program, which is I actually even find it hard not to get emotional when I speak about this because they have taught me, more than anybody or anything, and saved way more lives by their gracious, and we refer to them gifts after life. And historically, they've been around to teach anatomy, and now they're teaching people how to do procedures that they never would have had the opportunity to do. And so people like Rob Sandusky, who was there on that day, he's really been almost single-handedly the person who is previously a funeral, worked in a funeral home, and then he's just made this happen. So it's just this pretty amazing gift that we have used historically.
Well, thank you for the information on the Clinical Cadaver Program. We will post information about your program on the Continuing Professional Development website so the learners and the listeners can continue on with their learning and potentially even reach out. We were wondering, since we're on the hat rack, do you have any tips that you'd like to leave our listeners with, potentially about new skills acquisition or anything we've spoken about?
I always like to give our learners something to hang their hat on, George.
Yeah. Right.
This is your chance.
This is a chance, and I've got a nice hat rack behind me, and I guess what it'll come down to is sort of some key vignettes of what we talked about, but very briefly, is it is ultimately up to us, right? And when I say us, it's I'm taking us clinicians, right, to sort of say this is important. And I guarantee there's lots of things that scare us. And if I were to say I walk into a resuscitation tomorrow, my heart rate's up. That's a normal thing. World records are broken on world championships and Olympics because people's heart rate gets up. But then it crosses that border and it becomes dysfunctional and they don't perform well. So it is about, you have to accept the fact that there's a certain amount of creating discomfort, right? And putting yourself out there for opportunities that are there from a simulation. And again, I'd love to be able to say that everybody should have access to cadavers. Reality is that they don't, and maybe they will. So you also have to say, okay, work with what I have. And work with what you have, as you described, what's in your head. It's about thinking about that procedure, running through it, right? Performing that. What are the steps? Not just visualizing, but going through the motions with your hands if that equipment was there, and saying that those are all practice opportunities that you can work around, right? And then looking out for valued opportunities, and we have to make time because this is high stakes. And the other pragmatic thing is that when you call for help, it doesn't mean it's surrendering the scenario, right? So you could say, listen, there's somebody coming in, I think they might need this, right? And that person coming down doesn't mean that they're going to or should take it over, right? Saying, I'm asking for help. And that help can be, with you watching me. That help can be, again, sharing the experiences in your clinical setting when you hear that there's something going on in the next room.
Well, George, thank you very much for your time today. We are definitely going to have you back. Just before we go, do you want to tell us about the tractor?
So, yeah, it's something fun and has 100 times more in terms of purposes that you realize once you acquire one. It's just sort of, it went from being something that's of interest to something that's helping me do some sustainable work in the forest, in managing diseased hemlock and figuring out what's best to be logged, what's left best to be saved. But it's specifically the Massey Ferguson has a larger size bucket. And from a backhoe point of view, it'll be dig a deeper hole. I don't want to offend any Kubota people, but I am biased towards that, and it is red. Anyway, it's a
nothing better than a red tractor.
Nothing better than a red tractor.
George, thanks for being with us, and we look forward to having you again.
Thanks for the privilege.
So that was fun. What did you think of that?
Well, I see how the tractor fits in, right? With new skills, keeping up on that, right? But maintenance of it.
George is very humble. He actually was the champion of a project that helped to save an old-growth hemlock forest in southwestern Nova Scotia. Maybe we'll get him to talk about that next time he comes. Okay, here's what I learned. What I learned from him is to recognize discomfort. So recognize when you need to know a skill that you don't have, need to update a skill that you don't have or that you haven't used for a long time. I learned that you have to use what you've got. So that's that mental imagery part that we've talked about that you should practice. Use your hands, practice the things that you haven't done in a while so that you can do that. Or if you're in the process of learning a skill, practice. And then look for valued opportunities, I think he said. So those valued opportunities might be, it's what's available to you, really. It's learning from friends. It's learning from simulation and courses. And if you're lucky enough to have a clinical cadaver program near you, it's learning from a real life experience. I really liked his comment about the fact that that in medicine we do our performance 95% of the time and practice 5% of the time, and many other areas in life it's the opposite of that. So I think that's something that we need to really be thinking about. We need to be practicing these things time and again.
Yes, and I do appreciate the see one, do one, teach one, that you don't need to do just one.
Right. Well, it's not just one.
Yes.
It's
practice, and it's okay to practice.
That's right.
Keep practicing.
You've been listening to The Hat Rack, hosted by Dr. Bill McCulley and Leslie McAdam from Continuing Professional Development at the Schulich School of Medicine and Dentistry at Western University in London, Ontario, Canada. Technical assistance for The Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Beresnick. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack, that's all one word, thehatrack @uwo.ca. Additional episode information can be found online at www.schulich.uwo.ca/CPD. For The Hat Rack, I'm Stephanie Giberson-Kirby, Faculty Development Specialist at the Schulich School of Medicine and Dentistry, leaving you with something to hang your hat on.